Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Grand Rounds this week, where Shawn Silver, a second-year medical student at the University of Saskatchewan in Saskatoon, discusses quality improvement research in the critical care setting. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
So yeah, thank you so much for inviting our team and giving me the opportunity to speak here. So the title of this presentation, Driving Excellence in Developing Quality Improvement Program in Saskatoon Critical Care. This is following a Dean's project, which I was fortunate enough to present at the Anesthesia Journal Club. So the objectives for this presentation are going to go through some QI fundamentals, describe the pilot project that we worked on, and how we apply those the dimensions of quality improvement into our context. We'll provide some examples of QI in action, how it in real world examples about how it has improved patient care in critical care settings, understanding the rationale about why we did this and why it needed to happen in Saskatoon, and then how we can move forward and cultivate QI culture. So jumping in first, I know there's been a bit of exposure already to quality improvement and patient safety, but diving in the quality chasm, crossing the quality chasm in 2001 came up with the 6 key domains of quality improvement. And when approaching any sort of project, we want to ensure that we're providing the best quality care that we can for patients. And those include effectiveness, being patient-centered, timely, safety, efficient, and equitable. So as we approach this project through that lens, it was important to look at not just the single outcome that came from this, it was every step along the way of reaching that outcome is how each one of them interconnect and interplay with one another. So this is a fun quote. So without data, you're just another person with an opinion. So there was what we really wanted to do was find a way to offer the 6 dimensions of quality care the best that we could in Saskatoon. And I think that's what everybody shows up and wants to do. But without data, you can feel lost. You don't know what you're doing well, where you need to go, and what kind of directions we need to prioritize our resources. So the main goal of this was to be able to benchmark ourselves against national standards and identify areas needing improvement, and then being able to track progress and the impact of the interventions and outcomes. So another way to look at QI data collection is to observe it, how structures such as people in education and equipment inform processes such as policies and procedures, and how those then impact and inform outcomes. So it's important to consider organizational culture and how balancing measures and unanticipated outcomes can impact each one of the different domains. So along each one of these steps, it's important to measure the metrics and identify data and quality improvement metrics that can guide initiatives. It's very important to you can get hung up just on the outcome, but you forget how each one of these different domains can are so interconnected. So, um, for example, something that works really well in Calgary or Toronto, we can't just copy and paste that and apply it in Saskatoon because there's a different context. There's a different population. We have different resources, different protocols, different work culture. There's different values about what quality care may mean to patients. There may be a higher focus on cultural sensitivity, and that is the biggest priority for quality of care, where that is different in different settings. And obviously, the biggest goal is always to have standardized, protocolized care that is evidence-based. But even within our province, quality care in Saskatoon might not be the same as Prince Albert or Battleford or Regina. So the better way to standardize it is having an approach to try to identify how we can improve patient care best we can, and a standardized way of being able to individualize it for each of the settings and individual contexts. So there's a lot of different models and approaches to quality improvement and reviewing data and methodology, but um, they're all wrong to some degree. It's just finding what is useful out of each of them. So based on the information and the resources we had, we worked to develop an approach that would fit our context and our needs. And um, there was a need identified amongst healthcare, the multidisciplinary teams within the ICUs in Saskatoon, that there was a desire for this and there was a need for it to improve patient care and have standardized, protocolized approaches to ensure that we're implementing evidence-based practice. So yeah, we worked to develop a tool, a model, an approach that was somewhat useful. That was the main objective of what we're working towards. Um, so looking back at some of the barriers, why don't we have a QI program in Saskatoon? So during um, throughout many years, but especially over the past few coming out of the pandemic, there were other priorities. It's been a very challenging time in our healthcare system, and um, quality improvement and identifying the benefit of it has kind of been deprioritized. It's taken a back seat. And it could be argued it's rightfully so, it took a back seat to other priorities. And then there's also a lack of investment, both financial investment, fiscal, but also the resources and personnel, because it can be busy and you can't always rely on desperate medical students to work throughout the summer on these projects. So finding appropriate resources and um, demonstrating the benefit and that return on the investment is really important, and that does take a lot of work up front. But I think that it is moving forward, and even when we Dr. Gebhardt talked about looking at other barriers to quality improvement, and it's often there's just not an investment in the personnel to do it, but there is an increase in recognition of the value of it, and that's why we're getting provincial QI and patient specialty facilitators like Carla, who are able to guide and inform quality improvement projects. So moving on, QI in action. So um, the intensive care units, it's a team-based environment. It's multidisciplinary. It's a big team of physicians, nurses, respiratory therapists, pharmacists, social workers, physio, and everyone on the team. Um, Plus, it's complicated because we have the patients with us, and they're very high need and they're complex, and their loved ones are often there as well, and they have unique needs and challenges. So it's a complex team environment, and the ability to integrate evidence-based practice requires standardization of procedures, communication, and creation of a culture of safety. So in the early 2000s, there was an explosion of literature demonstrating that quality improvement initiatives could improve ICU delivery. As a result, many ICUs, including those in Saskatoon, implemented quality improvement initiatives that have a high degree of evidence, such as intensivist staffing models, head of bed elevation for prevention of VAP, and use of central line insertion bundles. So for the central line bundles, infections were associated with increased ICU costs and mortality. This project recommended the bundles, and it showed a sustained decrease in central line bloodstream infections over 18 months and has now become standard of care. This meta-analysis showed VAP bundles had a huge benefit. Interventions like head of bed elevation, daily oral care and chlorhexidine, and daily assessment of readiness for extubation and GI prophylaxis showed reduced VAP and decreased mechanical ventilation duration. And then implementation of ABCDE bundles showed reduced duration of mechanical ventilation and half the risk of delirium, which with no significant difference in self-extubation or reintubation. So this led to a widespread recommendation and implementation of practices in North American ICUs and organizations such as the IHI, Agency of Healthcare Research and Quality, both in the US and then throughout Canada as well. Healthcare Excellence in Canada, which combines Patient Safety Institute and the Canadian Foundation for Healthcare Improvement. And the CIHI tracks some of the quality metrics and mortality. Things such as mortality, nighttime discharges, ventilation rate, length of stay. Some provinces like Ontario have dashboards and a list of the QI data points that are collected for each ICU span, in each of the quality improvement domains. And in Alberta, the Critical Care Strategic Clinical Network provides QI tools and strategic direction to ICUs in order to meet individualized data-driven QI needs. One that's a little bit close to home and recent in 2024. So COVID-19 ARDS sometimes necessitated the use of sustained deep sedation. These patients were very deeply sedated with lots of infusions for very prolonged periods of time. However, it was identified that there was kind of a spillover of this, and patients were continuing this practice of prolonged deep sedation was continuing. And the question was this always appropriate, or was this a trend maybe in the wrong direction? So the ROSA study identified that in Edmonton ICUs, this was in fact happening, and that was through quality improvement initiatives and data collection. And their goal was to reduce sedative or analgesia infusions by 35%. And they did meet that initiative. And again, that's from being able to analyze the data and implement changes right away. So how did we start in Saskatoon? So we wanted to collect data, but we needed to start somewhere. So, the intensivists, especially Dr. Valiani and Dr. Gebhardt, who started the project, there were hunches and theories about some gaps or barriers or issues that were occurring in Saskatoon ICUs. But again, without data, it's just opinions. So we needed to find a way to support those theories and direct care and interventions. So chose to focus on delirium because it's a measurable outcome. There's validated scoring. It's multidisciplinary, which is very reflective of ICU care. It is complex, but it has been identified similar in Edmonton, a problem post-COVID, and the literature suggests that. So most importantly, it's a very patient-centered outcome. And then also chose to focus on ARDS. Again, the lung safe study showed that there was under recognition with identifying ARDS in patients, and that was definitely highlighted within COVID. So the objectives of the project, we wanted to develop a user-friendly and portable data collection tool that was very efficient, it was adaptable, and it could provide ongoing QI data collection and extraction. We wanted to develop quality improvement indicators to enhance the identification and management of critically ill patients, and then find a way to utilize that data to pinpoint strengths and gaps in the process and performance to ensure appropriate resource allocation. So, how we did this, we put a call out for, again, desperate medical student who was willing to do this. So I was very excited to jump on board. And then in developing the questions and the data metrics, we consulted with many of the ICU stakeholders. That included the physicians, nurses. We met with the respiratory therapist, managers, the bedside nurses, and actually ongoing, as I was doing the data collection, I was constantly asking the staff what they thought. Got the necessary approvals, developed project aims and metrics, and thankfully we were able to pull from other resources and identify those metrics and apply them to our context. We utilize REDCap as the data collection tool. Started gathering the data, patient information using SCM and then the paper charts, which is a bit of a challenge. And then myself, so again, I was a ICU nurse, so I was familiar with unit workflow, where to find things within the chart, SCM, and then I had some relationships and I was familiar with some of the staff, so I was able to foster that culture of adoption of QI. And then throughout the process, as I mentioned, the data collection tool underwent iterative refinement throughout. So one of the drawbacks of that was that it some of the data was less reliable because I was changing things and trying to optimize it, not just from the data that we were collecting, but also the flow and the time it took to collect the data and making sure it was efficient and easy to use. So these are a couple screen captures of the tool. So there was, I think, close to 1,000 data points that we could collect on a single patient. Or sorry, a couple hundred. So this is an example daily monitoring. So looking at how bedside nursing staff were the CPOT, so assessing for pain and discomfort in the patients. When were they documenting the RAS goals? Or sorry, if there was a RAS goal ordered, and then what the patient's sedation level was, and was it being documented, and then also identifying their CAM ICU, which is a delirium assessment. And then, on the right side, we were able to see, was the goal ordered, what was the goal, and then was there a rationale stated for what it was, or why the sedation goal was chosen, and then also was the patient restrained, and were there orders for that? Again, it was a huge tool, and it was really fun getting to familiarize with how to use it. So I was able to go in SCM and pull blood gas values, and then go to the bedside and get ventilator settings and input them into the tool, and then it would spew out their PF ratios and their and automatically try to identify patients who may be at risk for ARDS, who meet ARDS criteria. And then when we went over the screening questions on the right-hand side, it would automatically pop up and say they don't meet the ARDS criteria because their PF ratio is not bad enough. So there was a lot of utility, and it was a very powerful tool. And then we can pull data at any point very easily. And sorry, it was another nice thing is that it was very portable. I used my tablet. So I went bedside to bedside and just used my tablet. If I identified that there was a spelling error or a calculation error, I could go in and change the formula right away on the tablet, right at the bedside, and then I can pull that data. So going into our findings, so I went through the two ICUs. RUH and St. Paul's. There were about 450 variables, and both ICUs serve surgical and medical populations. So there was a little bit of a mixed bag of the patient population. Uh, the results here are examples. Um, and again, focusing on the delirium and ARDS. So in total, we looked at 164 patients, which were included in the data collection. So that was 115 at RUH and then 49 patients at St. Paul's. The discrepancy is just I was on crutches all summer and RUH was closer to home and I could get around on crutches easier. So that was the discrepancy there. Um, Patient charts were reviewed on multiple instances. So patient A, I would review them, go through, and then the next day I could do a second chart review and see how we were trending with that patient. So for the purposes of this, we called those patient days. So patients versus patient days. The time to do the data collection on a brand new patient through SCM to the bedside, it was about 20 minutes per patient, and then the repeat assessments were about 12 minutes. So going into some of our findings, and these are just quick examples of things that we were able to pull kind of pertinent to our goals because they were measurable, and just trying to identify strengths, gaps, and areas for improvement. So this one was the nursing documentation, the nursing flow sheet, and how we were doing at documenting it. So during day shifts for CAM ICU, there were a total of 157 charts that were applicable. Some patients may have been admitted at night shift, so there wasn't any point of data collection during the day. So that would be an example of why they weren't included in this. So 78.3% were charted appropriately, CAM ICU positive or negative. There were 21% were missing, so just not documented at all during days. And then unable to assess or unable to determine is there's certain criteria where the CAM ICU assessment is not reliable. So that might be for deep sedation, for example. So if they're a RAS score of -3, -4, -5, then you can't perform a CAM. But based on the sedation records in the rascals, this number was probably higher than it should have been. So there might have been a gap about knowledge about when it is appropriate to document unable to assess. And then on night shifts, kind of similar numbers, 37% unable to assess, 21% missing, and then 78% compliant with the documentation. So in total, 24 patients were CAM ICU positive. It's probably estimating that this was underreported, whether it was not documented or it just wasn't captured at that time. Another drawback was that when I was doing the data collection, I tended to do new patients and new admissions, and that was often heart patients, post-op hearts. So I wouldn't be able to track them longitudinally, and more likely we wouldn't capture delirium within their initial short stay. So it is likely underrepresented. 29 patient days during day shift, patients were documented as being positive. Or sorry, I apologize. 24 individual patients were CAM ICU positive, 29 patient days. During day shift, it was captured that 18 were positive, and then night shifts was 23. And per the nursing flow sheets, it is supposed to be assessed once per shift every 12 hours. But if a patient is positive, they should be assessed more frequently, so every 4 to 6 hours. And that was not, I wasn't able to identify that happening in any instances. Another one was the RAS, so that's the level of sedation. So this is for day shift and night shift. So this is just documentation. It's unlikely that nursing staff, and bedside staff weren't assessing patients for their level of sedation, but again, charted or it didn't happen. So compliance during day's shift, you could see it trending down as the day went on, and it was almost identical going down for the night shift. So um, yes, very, very similar trends and kind of as you would expect as the night shift goes down. So kind of like what we need to look at is why is this happening? Um, was a RAS goal ordered? So during the admission order set, there is a section, what is the RAS goal? And this should be a single value, and it is up to the nursing discretion to be +1 or -1 from that. So it shouldn't be a range. But 131 patients were reviewed, and there were 180 patient days. Sorry, I should say each on the flow sheet and during daily rounds, a new RAS goal should be ordered each day. So this was happening 80% of the time, 20% it wasn't. So again, trying to that is an important order, and we should be trying to identify that to ensure that we're meeting the goals and it is supporting the evidence about deep sedation. So patients who did have deep sedation ordered. So again, that's that RAS of -3, -4, -5. Current guidelines suggest that that's more or less it should just be applied to patients with elevated ICPs or TBIs, seizures, burst suppression, or ARDS. So those were documented as rationale, as you can see there, and then other accounted for 54%. The rationale for other, sometimes this was put in quotation marks in the order, so things like agitation and discomfort, airway alert, bronchospastic, vent synchrony, CRT, postcodes, resp failure. So kind of what it identified is maybe that there is and not stated three of the times where a patient was ordered to be deeply sedated. So kind of cueing that maybe this we are over sedating, or it's not being properly communicated or documented, or following guidelines about why patients are being deeply sedated. Looking at ARDS, so again, this time period was during the summer months, so it may underrepresent the actual numbers of ARDS patients we see in our ICUs. But based on the PF ratio, we had 20 patients met mild, 14 were moderate, and then 8 patients had severe ARDS criteria. And the reason, again, we wanted to identify this was the lung safe study showed that 40% of all comers for ARDS are under-recognized. So 49% of mild ARDS is under-recognized, 35% for moderate, and severe is 22. But it also showed that they did recognize 30% of mild, 46 moderate, and 23% of severe. And with this, the severe patients were documented that they may have ARDS, and their vent strategies maybe did reflect that, but the mild and moderate were likely under-recognized. This is just based off their blood work, but not necessarily documentation and how they were categorized or managed. And that can kind of it is somewhat reflected here with their tidal volumes. This was an example. So for mild, the range was 5.3 to 8.2 mils per kilo with a mean of 6.97, moderate, a mean of 6.86, and then severe was 6.05. It was valuable again with the QI. We could pull all the data on like driving pressures and what kind of PEEP and respiratory rate were we using, what kind of vent strategies, P-plats, use of inhaled nitric oxide, and then time of proning. Did they have an echo or not to try to look at right-sided pressures, things like that. So again, very powerful, and we were able to identify that maybe the ARDSNet strategies weren't it wasn't being recognized and maybe not being followed. So going in cultivating the cultures. So what do we do and how do we uh, build this culture of QI and drive change? So this is Cotter's 8 steps to implementing change. So the first step is building urgency. So you have to build a compelling case for change, and that's in part what we're trying to do here is try to get buy-in and show that there is a need for change, and we do need buy-in from staff, and you need to kind of create a culture where staff and employees and the workforce are no longer happy with the status quo. And it's estimated that about you need 75% of management to get buy-in for success to be successful. You need to next step is to build a coalition. So that's forming a powerful team, and that is what Dr. Valiani and Gebhardt did here was developing this team who are influential and can be change leaders. And then developing a strategic vision and a shared vision that can be very clearly communicated and shared and create that buy-in. Then enlisting more volunteers, getting QI volunteers to come in and again kind of cultivate that change and that desire for advancing care. Enable action by removing barriers. So finding ways to provide more training. So that might be training on CAM ICU, training on new ventilation strategies and recognizing ARDS, getting new protocols and identifying some resistors and eliminating those barriers. So next one is generating short-term wins. So a goal of this, we didn't share all the data, but there were some data metrics that we can say, hey, we're doing really well in identifying and proning patients early when we identify that they have ARDS, and that is a huge win, and it starts getting that buy-in. Or this is kind of a fun one, but again, because I knew some of the staff, I'd be going around and they'd kind of sarcastically say, "Oh, Shawn's coming. I better make sure I do my Braden scale, which is for pressure sores." So they did it, but now the documentation went up with documenting the Braden scale and identifying at-risk patients. And then you start seeing more prophylactic dressings going on because they're being deliberate about it and identifying this. So now we can start communicate, hey, look, we're doing really well in this area and we're improving patient care and mitigating the risk of pressure injuries. And then again, consolidating those gains because there are going to be setbacks, but going back and bringing those wins and successes and resharing that vision and moving forward and demonstrating those gains. And then embedding that change. And that is kind of the biggest work is really changing the culture. So, summary of what we did. So this was only a small piece, just a little bit of the plan. So the next steps, I think we identified that there is a need for this. We did identify some gaps. We also identified a desire for it. Initially, again, kind of the culture and the uptake, it was, oh, you're spying on us. Oh, your big brother is watching. I better make sure I document this. But as you communicate it and create that positive change and demonstrate that all we're trying to do is have that growth mindset and instill that desire for patient quality and optimal patient care. With the being patient-centered, effective, equity, efficient, and safe. The big goal behind this was just continuing to demonstrate that. And I think it's important to show that all QI requires an upfront investment, and it can be hard to demonstrate value when you're not going to see a return on that investment, big returns until years down the road, months or years down the road. But recognizing that upfront investment now is going to pay for itself tenfold. Um, it's going to improve patient quality. It's going to decrease cost, like the central line bloodstream infection rates. That decreases time. If we're able to mitigate delirium and appropriately sedate patients, we can maybe shorten their length of mechanical ventilation and shorten their length of ICU stay and mitigate that cost. And again, improve patient outcomes. So, as we're looking back, what we did, some of these examples, we need to ask why wasn't the RAS goal documented 100% of the time every 4 hours? Was it that nursing staff are showing up and wanting to do a bad job? That's obviously that's not it. But is it necessary for every patient? Is it appropriate all of the time? Is it redundant? Is the paper charting too burdensome? Were they doing it, but they just didn't document it and tracking it because there's too many barriers with that? Why are patients potentially oversedated? Is it still that post-pandemic culture that needs to be changed? Is it more patients in our context experiencing substance withdrawal, and that's not being recognized and it's being attributed to other factors? Is there a lack of awareness of current guidelines? Are staff too busy? Are they being pulled in too many different directions to be able to monitor all these patients appropriately? And so it's easier. I don't want to say it's easier, but it's more realistic to sedate them because it's safer for them in that moment when you're away with another patient. Why are we under recognizing delirium? Is it that it's not being done at a timely manner? Is there not enough recognition about hypodelirium and some of the factors that contribute? Is it that our ICU doesn't have enough windows? Is it too noisy? Is it too crowded? Are these things that are all contributing to delirium? And then why is there an under recognition of ARDS? Is it a lack of documentation from different centers? Is a patient admitted for 24 hours in North Battleford, and then all of their records aren't coming with them? It's not easy and accessible. Even for me, pulling patients who are admitted within 12 hours, trying to pull data from Nipawin Hospital, and then their flight transport record, and then their stay in the emergency department. Pulling all of that data is really, really challenging. So that might lead to under recognizing ARDS. And then a lack of identification because each of the disciplines are documenting on different formats, different records. It's not standardized. It's difficult to just pull data. You have to read longhand, and then it's just being communicated in verbal reports. So is that not connecting the dots when you're dealing with 20 plus patients? So again, we've identified that there's a need for QI, and there's a desire. I had, there was a lot of excitement when it starts saying like we can easily identify this, and now we can benchmark our physician performance. You can benchmark how you're doing against the next staff, and yeah, you can benchmark against other centers, other physicians, other weeks. Are prescribing trends of sedation different week to week? And so the future direction, I think one of the most concrete or biggest objectives here is to develop integration of electronic data capture and system-wide engagement, and that's through EMRs. So in places like Alberta and Ontario, right now you can go and look at what the delirium rates are in Grand Prairie and what kind of sedation infusions they're using in Medicine Hat. And you can pull that on a whim. And right now it's quite challenging because we just don't have that. So integrating a program like Epic is kind of the biggest step forward. That's a big hurdle, and once we're able to capture that, but being able to demonstrate a need and a benefit for that is where getting the buy-in from all of the stakeholders, and that is again when you look at quality improvement, it's the outcome measure is better patient care through better communication with the teams, but you have to look at each one of those processes and steps along the way in those balancing measures about all the stakeholders in each of those sections about how we can get buy-in and how we can create that culture and articulate that and communicate it to leadership and government and donors and get money for programs like this. So um, yeah, that is the kind of the big objective and going forward to just be able to pull that data um, quickly and efficiently and implement meaningful changes. So I that is more or less the crux of all this. So I just wanted to just really thank everyone for the opportunity to speak at this. But a huge thank you to Carla Flogan. She's the provincial QI and patient safety facilitator who has been absolutely instrumental. And she had a quote for everything. And Reezer, I would try to Google something, and it's just easier to ask Carla because she knew everything and pull it out off the top of her head. Um, so thank you so much. Absolutely incredible resource throughout this. And then Dr. Valiani for being very instrumental in getting this QI project off the ground, and then being a resource for me in at all hours of the day and night to be able to answer my questions and guide the project and make this presentation, put so much work into it. So just incredibly grateful for the opportunity and the support throughout this. So thank you.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.